This presentation is intended for general educational purposes only. It is not medical advice. It is intended to present you with our own opinions regarding the topics presented. It is not the intent for the presentation to be a substitute for seeking personal medical evaluation. It is commonly said that a person who treats themselves has a fool for a patient. All symptoms have a list of potential causes. Only a trained medical professional can optimally apply available tools to return you to your best possible health. It is our hope that this presentation makes you a more well-informed and better consumer of healthcare services.
I'm Dr. Sean Panzer, and I'm a gastroenterologist here in Denton, Texas. And if you've seen the video on our biography, you know that I did my stomach training, my internal medicine training down in Baylor College of Medicine in Houston, and then did my gastroenterology training at Johns Hopkins. And I've been in practice for 21 years, and I've been in Denton since 2009. Today we're going to talk about a really common problem in the United States, which is gastroesophageal reflux disease, and the numbers are fairly significant when you look at how many people are affected by reflux and its symptoms. And it's estimated that maybe 40% of Americans have a reflux episode, a symptomatic reflux episode once a month. Probably 20% have it once a week, and 10% of Americans have an official diagnosis of gastroesophageal reflux disease. So it's a really prevalent condition, not only among gastroenterologists, but also in primary care specialties such as family medicine and internal medicine. It's been said that gastroenterologists see maybe 5% of people who have reflux symptoms, and that might even be lower now, given that all of the medications that we use are over the counter. So many people are self-medicating and are kind of taking care of things at home. So the actual prevalence of reflux is probably even higher than we think. The official diagnosis of reflux is made using instruments that we're going to talk about in a few minutes. But obviously most people coming to see someone like myself or a family practitioner or an internist or a nurse practitioner, PA, are going to be talking about the symptoms that they have. And so the symptoms can be wide-ranging and can range from the typical burning type chest pain or burning in the chest area, an acidic taste in the back of the throat, chest pain, which obviously is not only caused by reflux but other things. And speaking of that, one of the most important things about chest pain is that you make sure that you have the possibility of heart disease excluded. Heart disease is the leading cause of death in the United States, and really anybody who's having chest pain ought to be seeing somebody and have some sort of a practitioner to make sure that this is not a heart problem. But we do know that once that's been excluded, that probably 50% of chest pain episodes are due to acid reflux, and about another third are due to spasm of the esophagus. Many of those are related to reflux events as well. So you have the typical kind of symptoms, and then you can have some other things. You might have problems swallowing as a manifestation of reflux. You might have regurgitation, where you really don't get so much burning, but you have it coming up in the back of the throat when you lay down at night, when you bend over to tie a shoe or pick something up. And then you can have people who have no symptoms at all. Maybe 25% of people who have reflux do not have any symptoms at all, and they might even show with things like swallowing difficulty or even respiratory type symptoms such as new onset asthma, particularly as an adult, recurring irritation of the airways known as bronchitis, unexplained pneumonia. You can even have dental issues where the teeth are abnormally worn in the back, and your dentist may notice that. You can even have sinus type issues, and so there are a lot of different things you have to think about, a lot of different symptoms you have to think about. Reflux can be on those on the list. Now, when you start getting into the more atypical symptoms, you're also going to be having other things that might even be more common. For example, if you have respiratory symptoms, reflux is on the list of potential causes, but other things are higher on the list, such as allergic type problems, sinus issues, and things like that. So reflux can definitely be mixed in with a lot of different conditions. And not only that, reflux can occur as a result of other things. So you might be treated for other things such as hypertension, for example. And a lot of those medications have side effects on the way the esophagus works. And so you end up having reflux after you get put on medication. Certain types of conditions, such as what's called scleroderma, which is a rheumatological problem, can affect the way the esophagus works. So your symptoms can be not only occur on their own, but can occur secondary to other things, such as systemic illnesses and medications you might take for other conditions. Now, to understand how reflux works, we first need to go through the anatomy, so I want to do that now. So this is the digestive disease anatomy, and I think you should be able to see this pretty well, but you can also see this on the internet. So when you swallow, food goes over the tongue here, and then it starts coming down this long tube called the esophagus. The lungs are on either side, and your heart's here, and your windpipe's here. The food then goes into the stomach where it mixes with acid. Muscles of the stomach grind up the food. It sits there a while, then goes into this C-shaped area called the duodenum. That area is important because two things empty there. One is the pancreas, which runs right here behind your stomach. It makes a juice that you need to break down food. It also makes insulin, which is important for your blood sugar control. The other thing emptying there is your liver, and it makes a lot of things, one of those being bile. Bile goes into tubes called bile ducts. They come into one main one that goes through the pancreas and out to the intestine. Your gallbladder is attached there and serves to store the bile until you eat, then squeezes the bile in to mix with the food. From there, it goes down about 23 feet of small bowel, during which time nutrients are brought into the body, water and waste is left behind. That comes out in the right lower part of the belly in an area called the cecum. Your appendix is there. As your water and waste goes up the right colon, across the middle, down the left colon, and then makes this S-shaped turn to where it comes out, water is removed, and the stool becomes firm. When you look at this anatomy, there are some inherent things that prevent acid from getting into the esophagus. Just from your knowledge of the treatment and in terms of medical therapy, obviously a lot of attention is paid to the production of acid. And as I'll say in a minute, or I'll point out in a minute, most of our medical therapy is oriented towards decreasing the amount of acid. But this is not a condition of too much acid being produced. It's a condition of acid getting into the wrong location. So the lining of your esophagus is basically like your skin. It's an organ that's designed to handle abrasion, not an organ that's designed to handle acid. And so it's like the skin, except of course you don't have hair. Whereas the lining of your stomach and the lining of the small bowel both are designed in such a way that they can reduce the amount of acid, counteract the acid, and keep it away from the surface of the stomach and the duodenum, and thus prevent ulceration. Your esophagus doesn't have that kind of protection, and so there are several things that help to keep the acid both out of the esophagus and also to minimize it. One of them actually comes from above the level of this particular picture, and that's your salivary glands. Your salivary glands make what's called bicarbonate. Bicarbonate will also neutralize, it works on your food of course, but also it neutralizes acid that comes up from the stomach. The second thing is that the esophagus has a set of coordinated muscular contractions called peristalsis. And so, as I said a minute ago, when you swallow, if my finger is food, the muscles above the esophagus contract, the muscles below relax, and so you have this nice smooth wave of contraction that pushes material from top to bottom. So that helps you, of course, swallow your food and your liquids, but it also helps to clear the esophagus of acid. And so there are three other defenses kind of built into the anatomy to help keep acid where it's supposed to be. The first of those is the way that the esophagus approaches the stomach. And so the esophagus comes through the diaphragm, which is this line right here, I hope you can see, and then it meets the stomach in the abdomen. In other words, out of the chest cavity, which is also known as the thorax. And so it makes this curve right here, as you see, and it's just a little bit harder for the acid to kind of make its way up through that area. The second thing you have is the diaphragm right here. And the way the diaphragm works is that when you breathe in, the diaphragm drops, and your ribs expand, and that creates negative pressure in your chest, and you inhale, and the process reverses when you exhale. And so what's happening in regards to the intestinal tract is that this diaphragm is dropping, and it, as you can see, it wraps around the lower esophagus here, and it kind of pinches us down. And this is particularly important at night when the pool of acid is against the back wall of the stomach here, and it's readily available to come up into the chest. But the most important thing that keeps acid where it's supposed to be is a structure in the lower esophagus that's called the lower esophageal sphincter. And lower esophageal sphincter is kind of, it's hard to define it anatomically, but it does, we do know that it's a high pressure area compared to other parts of the esophagus. And so normally it's closed tight, and as food approaches, it opens and the food drops into the stomach, and then it closes back up. About 70% of your reflux episodes occur because this valve is not functioning properly. It's opening when it's not supposed to, and that allows material to come back up into the chest. Other things obviously impact this, and of course the anatomy in your stomach does, because if for some reason the stomach is not emptying properly, or you have a blockage down here, which is what's in an area called the pylorus, then things are staying in the stomach a longer period of time, and as the stomach distends, it tends to make this valve open up. So if you have a slowly emptying stomach, like you might have in, say, diabetes, for example, then you have the stomach is full for a longer period of time, and thus you have a longer period of time for things to get a longer period of time and more exposure of the esophagus. One of the major things that compromises the anatomy, as we've described it, is this right here, which is called a hiatal hernia. So there are a couple of different hiatal hernias, but the most common one is what's called a sliding hernia, which means that it's like someone who basically took the esophagus and pulled the stomach up into the chest. And so instead of the esophagus coming through the diaphragm to meet the stomach, this top part of the stomach is now above the diaphragm. And so you can see now that this curvature that we talked about is missing. It's now a straight shot right up into the chest. The diaphragm is no longer supporting the lower esophagus. It's wrapped around the top part of the stomach, as you see right here. And this top part of the stomach is the part that makes acid. And so now you have a pool of acid that's present right here that's waiting. It's in the negative pressure environment of your thorax, and it's just waiting to come up. And so when you lay down at night or you stoop over or what have you, that acid is already ready. It's already there to come up into the chest. And then the most important thing that happens is that the valve that I was telling you about, this lower esophageal sphincter, is now moved up into the chest. And when that happens, it tends to make the valve open when it's not supposed to. And that's what's called a transient lower esophageal relaxation. And so that is, again, 70% of your reflux episodes are going to be due to relaxation of that valve. So a hiatal hernia is a really common problem in the United States. Probably 10% of Americans have a hiatal hernia, and people who have gastroesophageal reflux disease, it's probably upwards of 80%. So this is a real common problem. And again, a lot of things affect how all this works, and so that's what we're going to be talking about here in terms of management. So this is the anatomy, the anatomy, and obviously there's some other variations of things that happen if you get if you get certain kinds of surgeries done, what have you. That obviously affects the way this anatomy works as well. So when it comes to the diagnosis of reflux, from a practical standpoint, most of the time this is a clinical diagnosis. The official definition of reflux, gastroesophageal reflux disease, is for you to have what's called a Demeester score that's greater than 14.72. Now obviously people don't come into an office and say, I've got a Demeester score of 18, of 32, I need some help. This is a diagnosis that comes from doing a study that's called a pH probe study, where we actually officially measure reflux. So I'm going to tell you more about that in just a second. But so most of the time your doctor is going to simply hear your symptoms, and then they're going to put you on a medication, and then if you do better, then you had reflux, and if you are not doing better, then you're usually going to see a specialist, or there are going to be some studies that are going to be done. So, and in fact, that's what people do in general. They just kind of self-diagnose, and then they initiate the treatment, and then it goes from there. But so there are different tools that are brought to bear in terms of diagnosis. First of all, getting a clinical diagnosis is acceptable for the vast majority of people, because again, the medications are so good that you can almost just tell that's what it is. Obviously, the most important thing is that you want to make sure that you don't overlook a serious problem, which we'll talk about, some serious problems which we'll talk about here in just a few minutes. But there are different ways to get an idea of whether reflux is an issue. And of course, there are your usual things. Radiography type studies, which the main one being what's called a barium swallow. Barium swallow is an old test that in which you swallow barium, just like it sounds. You swallow barium, which we can see by X-ray, and it provides a contrast between the esophagus and surrounding structures, and you can see what's going on. So with that study, you can find hiatal hernia, for example. You can see narrowings. You can get some idea also if there's irritation of the esophagus lining, which is called esophagitis. And so, but it's a kind of a crude study. You obviously cannot get detailed information about the esophagus. You cannot diagnose precancerous conditions such as Barrett's esophagus, which I'll talk to you about in just a minute. And so it's older technology, but it does have its uses, particularly when a person's having a problem with their swallowing. The most common thing that you're going to encounter in terms of making a diagnosis is the use of endoscopy, what's called an esophagogastroduodenoscopy, also known as an EGD. And in that type of study, what's done is that you don't eat anything after midnight, and then you will come into a facility, usually you'll have your throat sprayed to numb it, and then you'll be put to sleep either by anesthesia personnel or through what's called conscious sedation. And then a lighted tube that's got a camera on it that's about as big around as the barrel of my pen here will be then inserted over the tongue, and it'll go through the anatomy that we just talked about. It'll go look at your esophagus, your stomach, and the first part of your intestine. And there's no doubt that it's the best test to evaluate reflux and its complications. It allows us to remove things, sample things. If you have problems, we can deal with those while we're there. And we can diagnose things like esophagus, such as irritation of the esophagus, irritation of the stomach, and also, of course, the precancerous condition known as Barrett's esophagus, and unfortunately, esophageal cancer as well. And so that's going to be the most common thing that we're going to end up using. And usually we're going to do that if you're having symptoms that don't respond to medical therapy, or you have evidence of some kind of a complication, such as swallowing difficulty, weight loss, throwing up blood, low blood count, some of the warning symptoms that may suggest a more serious problem. CAT scan-based studies are not usually part of a reflux assessment. It may be if you think there's a problem around the esophagus. Certainly weight loss, those kinds of things are going to will lead to a thought of doing a CAT scan type procedure. And so those are the main things that we bring to bear. One of the other things that's done is what we call a pH probe study, which I referred to a minute ago. And the way this is done is it's a catheter-based probe, and we we basically advance it over the tongue, and we attach it to the esophagus. Nothing is hanging out of you. The probe basically measures how much acid is coming up to the chest over a 48-hour period off medications. And this is really how we seal the diagnosis of gastroesophageal reflux disease. The study will tell us how many times the pH of your esophagus drops below 4. It'll tell us the percentage of the time. It'll tell us how many of those episodes were over 5 minutes, and also allows us to correlate your symptoms to reflux events. And this is particularly important when you have chest pain, because studies have shown us that a lot of people who get chest pain, of course, are going to go to the emergency room because they're worried about a heart attack. And so studies have shown us that if you can show a patient that 98% of the time when they had chest pain, they had a reflux event, it just makes them feel better in the middle of the night when there's no doctor to talk to, and thus it reduces utilization of the emergency room, which is a good thing. And so usually we'll do that kind of study prior to recommending surgical treatment. And so that's another thing that we'll do as well. There's another study that's called esophageal motility study, which is a tube put through the nose into the stomach and pulled back into the esophagus while you swallow. And that tells us if you have swallowing disorders. We don't do that quite as much as we used to, I think, but it is something that sometimes is appropriate, particularly if you have swallowing difficulty. And then there's a new study, a newer technology called impedance plasmathography, which is also catheter-based. It's put down through the nose, and then that can be helpful in terms of not only telling us about acid reflux, but also if you're having reflux of non-acidic materials such as bile, for example. And some people, they don't respond to medical therapy, for example, but their symptoms continue because they have the esophagus is being expanded by the material that's coming into it, and that study can be helpful. It's not particularly popular because it is hanging out of your nose, and people just don't tolerate that very well. So those are the main things that we bring to bear. And obviously in isolated instances we might need the help of, in some instances we might need the help of a head and neck surgeon, an ENT surgeon, in other words, to help us with symptoms. Respiratory doctors, again, like pulmonologists, sometimes allergists. It just kind of depends on the situation. So, but this is the main way we approach it. So now I want to talk about treatment. The treatment, as I said earlier, is largely oriented towards what's happening with the acid, the medical treatment. And so the first thing you have, of course, is your lifestyle type modifications. And these are really important. I mean, sometimes people think it's corny to discuss these things, but they're really important because the lifestyle things the things we do in our lifestyle definitely affect reflux like they do everything else, from diabetes to hypertension and heart disease and so many other things. And so, unfortunately, with reflux, we're dealing with what your lifestyle choices do to this valve here, this lower esophageal sphincter. And so basically anything that tastes good and is bad for you can give you reflux. So it's alcohol, nicotine, caffeine, peppermint, chocolate, fatty foods, all these things can cause this valve to open when not supposed to. Another impact that fatty food has on reflux is that the more complicated the food, the more the stomach has to process it for it to be sent into the small bowel. So the particle size of the food has to be reduced down to 3 millimeters or less, and it has to be diluted to a concentration that's about the same as the bloodstream before it's allowed to pass. So if you have a rich, heavy food, it's going to sit in your stomach for a while, and that's going to be available to come up into the chest. So how you eat is really important. Don't eat within 3 hours of going to bed at night, because when you lay down, then the food and the acid is along the back part of the stomach, and that's readily available to come up into the chest. So another important thing. Also, a lot of times people are told to prop the head of the bed up, and the reason is that you then have things kind of naturally run off back into the stomach, and initially if you just lay flat, it's free to come up. If you're at more of an angle, then it's naturally going to run off. And what's important about that is that at night you don't have as many spontaneous contractions of your esophagus, and you don't swallow as much. You don't make as much saliva as well. So that's why heartburn tends to be worse at night. And then you have weight loss, and weight loss is really important because obesity rates are just through the roof in our country right now. Ever since the 90s, it's an epidemic, really. It's affecting so many different things. Even we have terrible problems with childhood obesity. And when you put on that extra weight, you also get fat in the abdomen, but just having that extra weight compressing your abdomen and putting pressure on it puts more pressure, upward pressure, on the stomach, and then forces it up towards the esophagus. And so we know that reflux is seen a lot more in people who are obese. We also know that cancer of the esophagus is more common in people who are obese, and so that's really important. Smoking, as I said a minute ago, nicotine affects how this valve works, and of course you have a lot of other medications. So anytime we can maybe go to other medication classes, that helps us deal with reflux. But obviously reflux is going to be a secondary issue to heart disease and other risk factors that can cause strokes and heart attacks. So, but those are your lifestyle things. Another really good lifestyle thing is to chew gum. Not peppermint gum so much, because peppermint and mint can cause the lower esophagus to not function as well. But when you chew gum, you have more saliva production, and thus you end up with basically a natural way of neutralizing acid. And it's been shown in some older studies that you can get the same acid-reducing effect as 150 milligrams of Zantac twice a day by chewing gum regularly. So that's obviously an important thing to consider as well. Then you have the medical treatment. And the medical treatment, like I said, is mostly oriented towards decreasing the amount of acid made in the stomach. And so this ranges from your what I call topical therapy, like Maalox, Mylanta, Gaviscon, things like that, which neutralize the acid immediately, but but those medications work briefly. And so as soon as you make more acid, you got to take more antacid. So it can be a situation where you're taking just significant doses over and over again, and it becomes impractical at some point. The next class of medications are called H2 receptor antagonists, and these include your Zantac, your Pepcid, Tagamet, Axid, older medications. And these get rid of probably about maybe half of the acid that you make, and they probably give about 50% relief. So about 50% of people who take those medications will have complete relief initially. They're not used quite as much, but I still like them because some people come in who have not tried any medical therapy. They're generally free of side effects, and sometimes they work really well, especially if you can combine them with lifestyle changes. The next class of medications are your proton pump inhibitors, and these are medications that basically irreversibly block the acid-producing pump. Once they attach to the pump, that's it. You don't make any more acid until new pumps are created. So because of that, they tend to be longer lasting. They can none of them last a full 24 hours, but you can get maybe up to 18 hours where you have no acid being produced, and then the acid starts to come back. And so they're very effective. And these medications are your Prilosec, Prevacid, Capodex, Nexium, Protonix, and there are a whole bunch of those now. And so probably about 85% of people who start on that kind of medication will have complete relief from symptoms. However, the effect does not last forever. It lasts, if you look out maybe as short of a period as 2 years, those numbers will be down to about 40 to 60% of people who have complete response. All that class of medications is meant to be a once-a-day type therapy. Some people will go to twice a day, but the official manufacturer recommendations are to go once a day. And then you have other medications you might encounter, such as one called Carafate, which is known as sucralfate, and this really was an ulcer medication. But in some cases, I like to use it before a person goes to bed at night because it kind of coats the esophagus and the stomach, and I found that it can be helpful. A number of medications have been used in the past trying to make the esophagus empty better. Medications such as Reglan, which is known as metoclopramide. You might have heard of what's called domperidone, which is a drug that's not available in this country, but makes the stomach empty better probably. And there was one that was called Propulsid. Some of those medications are off the market. Reglan is one that I personally am reluctant to use because of neurological side effects, but occasionally I'll use it. There's another one called Baclofen, which is really one of the only medicines I know of that can reduce the transient lower esophageal relaxations we were talking about. Its use is limited by sedation. Side effects are not that hot. And the medical therapy has been revolutionary, quite honestly. The proton pump inhibitors in particular have been an excellent class of medications. Obviously, you probably have seen that there are a number of concerns that have been brought to attention in the media. And the proton pump inhibitors in particular have been targeted, it seems, in recent years. And it's really ironic because when they first came out, everyone was really concerned about them. And Prilosec was the first one, and you could use it for a year, and then you had to pretty much stop using it after that. And so then we went from that level of concern to a point now where they're all over the counter, and now we're starting to see concerns again. And a number of studies have been published that look back in time, what are called retrospective studies. They're studies that cannot prove that the drug caused a problem, but it was associated with a problem. So you may have seen things about dementia and bone loss and anemia and various vitamin deficiencies and infections in the colon and then kidney problems and just a number of different things. And quite honestly, those studies just have not been good quality. To prove that the drug caused the problem, you have to go forward in time. It has to be a prospective study where it's controlled, and the drug is the only thing that's different between two groups of people you're studying. And in this study, I just haven't seen studies like that yet. And people who review all the literature also feel that these drugs have been unnecessarily maligned. So I think they're safe medications like any medicine. They have side effects and things can happen that are unexpected. But I think as long as you're taking them under the supervision of a practitioner, then I think it's going to be a good thing. But those concerns are real. I have people coming in all the time asking me about it, and I've told this story many times to people in the last year or so. And so anyway, that's the medical therapy. Then you have the surgical repair. And the primary one that's used is what's called a Nissen fundoplication, like Nissan but with an E. And so the intention of a Nissen fundoplication is to restore the anatomy as you see it right here. So usually it'll be done when a person has a hiatal hernia. And so the surgery is done laparoscopically, meaning that you'll get a few small incisions along the rib cage, one at your belly button, and then the surgeon operates through tubes. And what they want to do is they want to bring that hiatal hernia back into the abdomen, in other words, bring the stomach back down. They want to tighten up the diaphragm opening so that the stomach can't go back, and you restore this support here, and they kind of tack the stomach down. Then they take the left side of the esophagus and wrap it around, left side of the stomach and wrap it around the lower esophagus, and that bolsters it up. Medical therapy changes the chemistry of what's your reflux, but it does not change the actual process of reflux. Fortunately, for the vast majority of people, just by changing the chemistry, their symptoms go away, but 15% or so will not have relief. Plus, if you have symptoms where you think that the acid is going down into the windpipe, causing respiratory symptoms, voice changes, which I didn't mention earlier, actually voice changes can be a sign of reflux, then medical therapy is not going to be that hot, because again, you're still bringing that stuff down, even if it's not acidic, and that's just not good for your lungs. And so the surgery is a good one. It's been around a long time. It became excellent when they started doing it laparoscopically. For most people, you go home that same day or the next day, and it works really well. Like any kind of hernia repair, it has its downsides. And so when you look, the longest study I know of goes out 7 years, and we know that by the end of that period of time, probably 20% of people will be back on medical therapy. About 15% will have to consider having the surgery redone because the wrap has come undone. We know that probably 30% will have some swallowing difficulty because of the just scarring in the area, which responds to us just stretching the esophagus out with endoscopy. And about 70% will initially have what we call gas bloat syndrome, which occurs because you can no longer belch. And so when you swallow air, air is mostly nitrogen, and nitrogen does not pass the intestinal tract. It does not get absorbed out of the intestinal tract, so you either have to belch it out or pass it out down below. But that usually does respond to some pretty basic medical therapy, and I've not seen that be a really big issue with the surgeons here in Denton. So it's a good surgery. Then you have some other things that have been tried to make it a less invasive process, and one of the ones that's out now is called a TIF, T-I-F-F procedure, and that's done through. It does not involve any cutting into the abdomen. It's done through the esophagus. Basically with the assistance of an endoscope, and these procedures all kind of have the same goal. They kind of lengthen the esophagus a bit, and thus they help to decrease reflux. And there have been a number of these that have come out over the years. The TIP procedure, some people are doing it. There's a lot of question about how long it lasts and how durable the changes are. So I personally don't send people for that. There have been just all kinds of different things that have been tried. There was what's called a Stretta procedure, which applied electrical energy to the lower esophageal sphincter, that I actually liked. I did quite a few of those years ago, but the company went out of business, but the results were quite good for that. There was what's called Intera, which was a liquid that was injected into the wall and thickened the wall. And it also worked. The main problem was that it had some really terrible complications. So a couple people died. It was taken off the market. There's also what's called a link system, which is a set of magnetic beads that they wrap around the esophagus. That's currently available. And so when you swallow, the beads expand out and let the food pass, and then they come back together. There have been some problems with that as well because of swallowing difficulty, and so I don't think that's a good option. There was one called EndoCinch, which puts stitches in through a scope. Those didn't hold, and so the surgeons have gotten so good at reflux surgery that I really feel like that's the way to go. And I like the surgery, I do, and especially if you're less than the age of 50, it's a great option because when you look at it compared to medical therapy, your expenses are lower. The benefits exceed the risk as compared to maybe people over the age of 50, where your risk of surgery is higher. Then medical therapy may be a little bit more favored, but less than the age of 50, I think it's a really good option. So, what are the consequences of reflux? The one that everybody, people are obviously most concerned about is esophagus cancer, which is devastating. It's a deadly cancer. It usually has already spread locally, at least, and even more distally by the time it's discovered. And it's a cancer that unfortunately is increasing. And for most people, some people would say that every time this happens, but there are some people where this does not happen. But for most people, esophagus cancer starts off in a precancerous form called Barrett's esophagus. And Barrett's esophagus occurs in about 10% of people who have acid reflux. And your chance of getting cancer during your lifetime it has been quoted as high as 1 to 3% chance per year. But really, more recent studies have shown that your lifetime risk is probably about the same as your lifetime risk of getting colon cancer, which is about 6% if your average risk. So it's about the same. In my calculations, it's about the same for Barrett's esophagus, about 6% lifetime risk. Now, if you have Barrett's esophagus and then have what's called dysplasia, then your risk is higher. And so in that situation, you move closer to cancer, and that's a whole different ballgame. But as far as your generic basic Barrett's esophagus, which is known as intestinal metaplasia of the esophagus, that's your risk. And by the way, Barrett's esophagus occurs when the lining of your esophagus changes from the skin type lining to a lining that's like the intestinal lining, and that's genetically unstable and thus prone to developing cancer. As mentioned earlier, that you can have acid come up so high that it will get into your windpipe, and so you can have respiratory complications, like I mentioned earlier. About 10% of people will get what's called an esophageal stricture, which is where you have scar tissue laid down on the inner wall of the esophagus, just like you have healing elsewhere in your body. And so if your opening gets below 12 millimeters, then you're going to start having trouble swallowing. And so if you have trouble swallowing food, you really need to, it really swallowing problems of any type, but particularly that, you need to get that looked at, because that food could get stuck. Not only that, esophagus cancer presents with the same type of symptom, and so we can't tell you just because you have trouble swallowing once in a while or all the time if you're not developing a narrowing due to scar tissue or to a growth being in that area. But generally speaking, we can fix that by stretching the esophagus out and getting rid of the scar tissue when we do endoscopy. So we can do put a balloon across here, or we can do what's called a bougie dilation, where we put a wire in the stomach, bring it out over the tongue, and then run a tube over that called a bougie, which is shaped just like the barrel of my pen. It has a narrow tip and flares to the diameter that I want, and we just advance it over that wire and fully insert it in the esophagus. And that'll usually keep it open for, on average, a couple of years. Some people need it more often than that, some need it less. But obviously, if you develop problems where you're, and of course, any weight loss with swallowing difficulty or some of the other things I mentioned earlier, you really need to get that looked at. And that's one of the reasons the antacids the over-the-counter antacids are given in 2-week blocks, because they don't want you getting better and then missing an important diagnosis such as esophagus cancer. So reflux, just to summarize, is a really common problem. It's one that's increasing in frequency. It does have some severe consequences. You're always better talking to a practitioner of some type about your symptoms, just to make sure you're not in a higher risk group because of symptoms that you may just be minimizing, what have you. When you take medications for your short-term relief, you have an episode every once in a while. That's okay. That's, like I said, that's pretty common. But you need to make sure that you see somebody if you develop any symptoms that are more significant. And again, that's what we're trained. The gastroenterologists are trained in this, and we're all experts. And whether you come to see me or go to see somebody else, think about what I said in this video. Frame your questions accordingly, and I think you'll get a lot more out of your visit with your gastroenterologist. So I deeply appreciate your time, and appreciate you purchasing access to this video, and I hope it was helpful, and love to see you in the future. Hi, I'm Sean Panzer, and I'd just like to take a few minutes just to let you know about some of the different things that we offer through my office. Obviously, I'm a traditionally trained gastroenterologist from Baylor College of Medicine in Houston and Johns Hopkins up in Baltimore. But obviously, things change over time, and so I think it's important that a person also get kind of keep up with the times and be contemporary. And you also want to balance that with things that you know have worked from the past, because a lot of times things come up that are that seem to be awesome and something you want to put in your practice right away. But a lot of times you need the kind of the percolation of time to make sure that the procedure is truly safe and is one that's going to benefit a patient. And that does take a combination of experience and knowledge of the literature and other things. So I just want to make you aware of some other things that we do. Of course, you can obviously see me in the office, kind of the traditional way, but I also have telemedicine, which allows a person to have an office visit, a follow-up office visit over Google Duo or the iPhone FaceTime. And I can't do new patient visits that way, but it is covered by insurance and Medicare. And I use that a lot in people who have to drive or can't get here easily, or off in other places like in school, that kind of thing. We also have a nurse practitioner named Tony Perkins. She's sees patients while I'm here in the office, and her practice is mostly focused on helping people who need to be worked in that cannot be worked into my schedule, and so she's also available. We also do in-office hemorrhoid banding with a system called the CRH O'Regan system, and this is kind of the latest version of hemorrhoid banding. I've done hemorrhoid banding since I read about it, the endoscopic version in 1996, but this newest version is basically a painless version that does not require colon preparation. I can do it right here in my office, again covered by by Medicare and also by private insurance. We also have a type of radiology device that's called FibroScan. This allows us to quantitate, not only it uses an ultrasound technology which allows us to quantitate how much fat is in the liver, and it also allows us to tell liver stiffness, which correlates to how much scar tissue is in the liver. So if you have a chronic liver problem, such as hepatitis C or fatty liver, then we can use this to, in a non-invasive way, to give us an idea of how much scar tissue you have. This may lead to a change in your management, either through medical management or to referral to a tertiary level medical center slash liver institute for more for access to possibly clinical trials and other things. But in the past, the only way we could do that was with liver biopsy. You can also get similar information from an MRI, but MRIs are very expensive and it's very difficult to do a good MRI. The last thing I want to talk about is an alternative medication line that we're developing for digestive diseases. And the alternative medications are it's a big industry. There are a lot of people that carry the medications, drug stores, grocery stores, and all that. And there are just so many different products and so many different things out there, and it's just kind of mind-boggling, really. The unfortunate thing with a lot of those, for the vast majority of these supplements and minerals and herbs and these things, is that there's just no clinical data. So a doctor like me who prescribes your standard prescription medications, all of those had to go through scientific studies in which they were compared to placebo. They went through animal trials. They went through patient trials. And then a lot of times we have years of experience with these. And so we know that they work better than a placebo. But a lot of people are turned off by big pharma and the expense and just the suspicion that the medicines are not good for them, side effects, this kind of thing. When you turn to alternative medications, you have even a worse problem because you have so many different chemicals that are put into one product. You don't know which one works. You don't know which one may be interacting with medicines you're already on, that kind of thing. But people seek that care a lot and go to non-traditionally trained individuals and put a lot of trust into people that have not spent a lot of time either practicing medicine or studying medicine. And so what I'm trying to do over the last year is educate myself more about the things that are out there, try to get as much information as I can, scientific information, to help me make decisions as to what may work and what may not, and what does not work. And so that's what I've been trying to do is we're putting together a product line that will allow us to treat the things that we see. And so we're going to use these as a combination with the traditional medications, and hopefully we'll get better results as a result of that. These medicines will be available in the office. They're also going to be available online on eBay store as well. And so please give them a look. And obviously when you come to the office, I'll definitely describe those. But again, the idea is to get some kind of a product line that I can feel good about in terms of the production and also standardization, and where we can combine it in a controlled way, as compared to just going out and taking a handful of different supplements that may be countering each other, or just not doing anything for you and wasting your money. The last thing I'd like to talk to you about is hydrogen breath testing. This is technology which allows us to measure how much hydrogen you're exhaling, and our bodies don't make hydrogen, only bacteria do. And so what this allows us to do is to look at, to see whether or not you are possibly malabsorbing different things, such as lactose and lactose intolerance, fructose intolerance, and also what's called SIBO, which is known as small intestinal bacterial overgrowth. This is a condition in which you have bacteria in your small bowel which should not be there, and in too high quantities, and as a result they are interfering with the function of the bile and also the digestive juice made by the pancreas and by your small bowel lining. When that happens, then you don't absorb things the way digest and absorb things the way you're supposed to. They go lower in the bowel where they're broken down by bacteria, and that's fermentation, and that can lead to anything from gas and bloating all the way to diarrhea and even weight loss. So it's something that's part of our workup of symptoms like gas, diarrhea, and bloating. So we're, like I said, we have these available now. We're always looking to add things that I think are going to be helpful. These things are covered by insurance, and with the exception of the supplements. And I hope you give these things a look. Thanks for your time.